Hello, today we will look at insulin, and we are dealing with patients now that have already been taking oral medications for diabetes type 2, and we will now try to step up our game and giving insulin because the oral tablets are not enough. Let's say, for example, that the patient already took metformin, he took GLP-1 agonists or DPP-4 inhibitors or SGLT2 inhibitors, and we have tried everything. The sugar level in the blood is too high. We can see that in the fasting blood glucose levels. We can see that in hemoglobin A1C values. For example, if the hemoglobin A1C values is high, then we're dealing with a sugar level that is the average in the last 3 months. And if we see that the average is around 6.5% or more in younger, fit patients that are having no other diseases, then we say that we need to increase the dose because we need to somehow get patients under 6.5% if we are dealing with younger patients. If we are dealing with the normal patients, the typical, I would say 50, 60, 70-year-old patients, then we can be under 7%. And if we are dealing with very old patients or patients with limited life expectancy and with many, many diseases, then we can accept that we are below 8%. And now that we see that the patient is taking oral tablets, the ones what I listed, metformin or GLP-1 agonists or DPP-4 inhibitors or SGLT2 inhibitors, and we see that the level is higher than these percentages that we said, either 6.5% or 7% or 8%, depending on the patient's condition, then we need to start insulin, okay? The one thing I usually do when I see that the patient is not really in the normal glucose level with these 4 medications that I listed is to try sulfonylurea. That's my last option if I really don't want an insulin, and if the patient really tries to convince me as a doctor that please, I don't want to have insulin because this is injections, this is not just an oral tablet, then I say, okay, let's try sulfonylurea, and if this does not work, then I need to add insulin. And if we add insulin, what type of insulin do we talk about? We can have, for example, neutral protamine hagedorn, that is abbreviated as NPH, neutral protamine hagedorn, or we can have detemir, or glargine, or degludec. And depending on the insurance company and depending on the country that you are in, that will actually make or break the decision of which one we will give. Because I would say the glycemic efficacy, so the efficacy of all these insulins are very, very similar. So it's not a question about how good is it. It is more a question about which one is actually more covered by the insurance company and which one should we then, based on money, take. And I would say, for example, in Austria, where I work as a doctor now at the moment, we would focus on glargine, and glargine is a really, really advantage. The advantage here is that it's the cheapest, and the insurance company loves it, and therefore I usually give then insulin glargine. And this is a basal insulin. Basal insulin means that they work a longer period. This is a long-acting insulin instead of giving a short-acting. And the reason why we always start with a long-acting now is because it works much, much longer, like one day, one can say usually 24 hours and so on. And therefore I usually say that let's try with basal insulin glargine at the evening time, and then we will start with a dose of 0.2 units per kilogram. So if the patient have for example 80 kilograms, then that would be around 16 units daily, and we would start the 16 units at evening time. And if the patient is not 80 kilogram but much less, then we say that the minimum amount that we need to give daily is 10 units. And in another case where we have a patient who has really high blood glucose levels, let's say more than 250 milligram per deciliter or more than 13.9 millimole per liter, or we can say more than hemoglobin A1C more than 8%, then we actually need to start with a dose of 0.3 units per kilogram. So not 0.2, but instead we will start with 0.3 units per kilogram. And if we take this same example of 80 kilogram patient, that would then mean 0.3 times 80 kilograms, and that is 24 units daily instead of 16. So we said that we have hemoglobin A1C, and then we have also something called fasting blood glucose levels. The hemoglobin A1C, as we said, is the average in the last 3 months. And the reason why I prefer this one is because the patient, if they know, the patients, if they know that they have a blood sample test by the doctor's office, then they usually try to make a diet the week before or the days before. And therefore, usually the blood glucose is better than actually it is in normal state. And therefore, I usually take the hemoglobin A1C because that will tell me how much is it really in the last 3 months. But whenever we start now the insulin, then we need to check the blood glucose levels every day. And we will check that every day. And every 3 days, the patient will come to me as a doctor, and then I will look at the chart. He will write all the values down that he measured. He will measure the blood glucose levels in the morning, lunchtime, and evening. And then we can see if we need to increase the insulin dose. So we started with the basal insulin, glargine, for example, in this case, 0.2 units per kilogram. So in an 80 kilogram patient, we started with 16 units in the evening time. And then he measured the glucose in the morning, lunchtime, and evening. And if I see that the target level, and now we are not dealing with hemoglobin A1C because I cannot take hemoglobin A1C because that's the average in 3 months. Here I need to take the fasting blood glucose level. So the fasting blood glucose level. That means if we see that the fasting blood glucose is more than 130 milligram per deciliter, or in another unit, it's more than 7.2 millimole per liter. If we see that this is the case, and we are giving this insulin and it is still higher than these values, then we will increase it with 2 units every 3 days. So 2 units every 3 days. And if we see now that the fasting blood glucose levels is much, much higher, I'm talking about more than 250 milligram per deciliter or more than 13.9 millimole per liter, then of course we need to increase it even faster. So not 2 units every 3 days, but rather 4 units or more every 3 days. And I would say, in conclusion, we can say that we have a patient now, he took oral tablets and we gave him this insulin. The important thing was that we need to keep the oral tablets still. So we will not reduce all the oral tablets and then jump to insulin directly. We will rather start slowly, and then slowly we can remove the oral tablets. And metformin, for example, GLP-1 agonists, DPP-4 inhibitors, and SGLT2 inhibitors does not have to be stopped. We don't stop these medications. The ones which we have to stop actually or reduce drastically, at least 50% of the dose, is sulfonylurea and pioglitazone. Because if we give these together with insulin, then we can have a hypoglycemia, which is a lower level of glucose in the blood, less than 60 milligram per deciliter or less than 3.3 millimole per liter. And that's dangerous because then we will get dizziness and actually unconsciousness and so on. So in conclusion, when you give insulin, decide which one you take based on the insurance company, based on which is the cheapest for the patient. Because as we said, they're working almost the same. So there's no reason to think that if something is much more has a much higher cost, then it is much better. Okay, it is not the case. So please take the cheapest out of these 4 that I mentioned: neutral protamine hydrogenone, detemir, glargine, and degludec. And I'm preferring glargine in this country. You have to check your own country, but in Austria we will give glargine, and as we said, 0.2 units per kilogram and a minimum of 10 units daily in the evening. Thank you very much for listening. Have a nice day. Bye-bye.